With the advent of novel agent induction therapy that usually combines a proteasome inhibitor and a immunomodulatory drug, the frequency of patients coming to transplant in complete response or very good partial response is quite substantial, upwards of 60%. Patients who have a measurable M spike, and the lower limit of measurement is usually 0.2 grams per deciliter, have probably demonstrated some element of therapy resistance and that it was not possible to eradicate the protein and put them into a VGPR or better pre-transplant. And what we found is that even though these patients get a deepening of response with transplant, being moved from a VGPR to a CR to a stringent CR, and stringent CR to an MRD negative stringent CR, these patients still do not have as good an outcome as those patients who come into transplant in very, very deep response. And we believe it's a reflection of the inherent biology of the myeloma at the time of diagnosis. When we see these patients at the time of diagnosis, patients who have biologically low proliferative index, favorable genetics, and chemotherapy sensitivity will achieve a VGPR or better before transplant. And when they don't achieve that, it says more about the inherent biology of their disease than it does about the technique of stem cell transplantation. And so we're well aware that although patients we believe who get transplant have a better outcome, there is no doubt in our mind that those patients that achieve a very deep response prior to transplant will end up doing better. Having said that, that does not mean that patients who have not achieved a VGPR at the end of a single induction should receive a second induction therapy prior to stem cell transplant in an effort to deepen the response. To answer that question, you really would require a prospective randomized trial. This is more prognostic and a reflection of the biology rather than a therapeutic guideline. So it's true that patients that don't achieve a VGPR pre-transplant don't do as well, but that doesn't mean that patients who don't achieve a VGPR should cross over to a different induction therapy or have intensified induction in an attempt to bring patients into a VGPR pre-transplant. We don't have the data to indicate that that guides therapy. It's simply a reflection of prognosis and what it means for the patient post-transplant in terms of the likelihood of having a very prolonged disease-free survival.